Hello, y'all. We are going to, over the next 10 minutes, talk about postpartum care for birthing people living with HIV. And our goals are really going to be thinking from the inpatient setting to marching out to outpatient and planning someone's postpartum course. The first step we'll talk about is that immediate infant care. What needs to happen in the LDR? A lot of these processes happen automatically, and Prentice is really such a well-oiled machine, but things that we really want to make sure that we are consciously aware of as happening in the background, or making sure when that communication occurs that it is seamless. The concept here is that we want to minimize infant exposure to maternal blood and bodily fluids. And one of the mainstays of how we do this is an early infant bath. This occurs in the LDR prior to any injections, specifically prior to that vitamin K injection. We want to wipe that infant's skin down. We then want to administer infant antiretroviral prophylaxis right away. We'll talk about the nature of what type of prophylaxis we give in a moment, but this includes all babies, includes low birth weight infant babies, those with low APGAR scores. We really want to make sure that we can get them these medications as soon as we possibly can. In terms of breastfeeding, hopefully a lot of this conversation has happened in the outpatient setting, but certainly if there's a new diagnosis and we're talking about this, we want to make sure that we're engaging in culturally affirming shared decision-making regarding what those risks look like, and we'll talk about what those specifically are. I mentioned we'd circle back to the medications that we give, and this is a really important study, the PACTG 1043 trial, that really reshaped how we think about postnatal prophylaxis. The concept here is that, at the time of this trial, the standard of care was to give neonatal zidovudine postpartum, or AZT, to infants for 6 weeks. And we knew that that dramatically reduced the risk of perinatal transmission, and particularly in high-risk exposures. But what this did is it took birthing individuals that were at high risk of perinatal transmission and randomized them to either receive zidovudine, or double therapy with zidovudine plus nevirapine, or triple therapy with zidovudine plus lamivudine plus nalfinavir. And in this randomized trial, there's two things that I want you to remember. The first is, if you look at these blue bars, these are infants that were infected in utero, that we, from the timing of the testing, realized that that infection had occurred during gestation. And what you can see is there's really not too much of a marked difference between those that got zidovudine and double therapy and triple therapy, right? And the concept here is that we know that if in utero infection has already occurred, monotherapy with zidovudine is not really going to do anything. But where the real impact was those infants who were infected intrapartum, and those are depicted in the green bars, compared to zidovudine, where there was around a 5% risk of perinatal infection. Those who got double or triple therapy had that risk cut in half. And this was statistically significant and really clinically significant, that we could reduce the risk in these incredibly high risk exposures to be around 2 to 3%. And so this is a trial that really changed the landscape, that for high risk pregnancies, we offer the infant triple therapy. Now you might say, well, why not double therapy instead of triple, so that we're exposing them less? And the thought process is that by giving double therapy, we might promulgate resistance in those who do in fact become infected. And so triple therapy would reduce that risk. So how do we define high risk, right? In the PACTG 1043 trial, it was extraordinarily high risk. But maybe we want to expand this a little bit further. And so you learned about this slide before. This is, I think, a really important, the Mandelbrot study in clinical infectious disease that taught us that, the ways to, that it's high risk to not have already been on antiretrovirals before pregnancy, or to start them later in pregnancy, or to have any detectable viremia throughout the course of pregnancy. Those all dramatically increase the risk of perinatal transmission. And so building off the 1043 trial, as well as this French cohort data, we have defined infant risk status as high risk if at least one of the following is present. That includes infants born less than 33 weeks, recognizing that prematurity is a risk factor for perinatal HIV transmission, anyone who had detectable viremia after 28 weeks, any woman who didn't receive antepartum antiretroviral therapy, anyone who started antiretrovirals after 13 weeks, anyone who became infected or seroconverted during pregnancy, that's a risk factor for perinatal transmission, and anyone, of course, who had been diagnosed during labor or postpartum. If any of those are met, we'd consider that infant high risk and recommend triple therapy. Anyone who doesn't meet any of those criteria is defined as low risk. In terms of the specifics of the regimen, they're listed here. I won't read them off to you, but this is important to go back and reference this and make sure that we have the right dosing and the right time frame. What I do want to emphasize are a few points. One is that while we would consider for high-risk infants continuing the zidovudine for a full 6 weeks, the nevirapine and lamivudine can be discontinued if the birth PCR is negative. In addition, we want to initiate this, I mentioned this before, but right away after delivery. And then for preterm infants, we want to be aware that there's special dosing considerations. And so for infants that are preterm, we want to reference our institutional protocol that defines, birth gestational age windows and how we would dose this. And then for those that are extremely premature, we would call our pediatric infectious disease colleagues to help guide us. In terms of infant feeding, this is an area of pretty significant controversy. Important tenets to remember that HIV is found in breast milk, and that if women have detectable viremia, an additional 15 to 29% of infants will be infected. Right? This is unequivocally a mode of perinatal transmission. Women living with HIV in high income settings are often, because of this risk, recommended not to breastfeed. However, we've come to realize how important it is to respect the cultural norms and to engage in shared decision-making for women living with HIV. What's really important to remember is that mixed feeding, meaning breastfeeding and formula feeding, kind of alternating between the two, has actually a higher risk of HIV transmission compared to exclusive breastfeeding alone. And so for that reason, it's important that we talk to folks right away so that they know that it's really not okay to breastfeed when their mother-in-law is visiting to try to avoid disclosure, but then formula feed, in other settings. And so we can support them in navigating that decision and then troubleshooting how to make this work. But we also should know that, they're changing guidelines in other contexts. The U=U we'll talk about in the Safer Conception module. That, this is something that is a dynamic consideration. And so while the risk is certainly low in someone who is on antiretrovirals and has sustained viral suppression, it's hard to prove that there's zero risk. But engaging in that shared decision-making about the benefits of breast milk, the benefits of direct breastfeeding, what sustained breastfeeding, exclusive breastfeeding could look like, and then, what these risks look like. I think it's really also important to flip this on its head and say, right, if we think it's so important to dialogue around this with birthing people living with HIV, it's probably really important for us to know the HIV status of people who are breastfeeding. And so thinking about what that could look like from a public health lens. This is all really about the inpatient care, but when we think longitudinally, we want to remember that we want to set these birthing individuals up for success afterwards. And so referring people to specialty HIV care if they're not already linked, and considering possible changes in antiretroviral therapy. If someone has been on a complicated regimen to support the prevention of perinatal transmission, can we simplify her regimen? Can we convert her to a once-a-day regimen? What are her plans for conception in the near future? What would that look like? In terms of contraception, we want to make sure that we're checking the CDC guidelines at any drug interactions with antiretrovirals. We want to make sure that we're monitoring for adherence and postpartum depression. This is particularly true for individuals with a new diagnosis. So considering a follow-up visit within 2 weeks after delivery. In terms of new individuals with a new diagnosis of HIV, it's important to remember the entire family context. And what I mean by that is thinking about any older children, right? Has this person birthed before? Have those infants been tested? Was this person tested in a prior pregnancy? When was that last negative test, so that we could time who needs to be tested in that family unit? And then following up with sexual and needle sharing partners is really important. So thank you so much for your attention and being a part of boot camp, and we look forward to this discussion in person.